Hello everyone. A very warm welcome to everyone here this afternoon. Welcome to all our visitors and everybody here at the Lakeside Theatre, and also to all of those who are joining us remotely from across the UK and across the world. So a very warm welcome to you. My name's David O'Mahony. I'm the Dean of Partnerships here at the university, and I'm chairing today's event with the launch of our new Institute of Public Health and Wellbeing. I'm really excited to be here today and really excited with the launch of our new institute. This event represents the culmination of an awful lot of hard work by colleagues inside and outside the university to allow us really to consolidate our considerable strengths in research, education and practice in the vitally important field of health and well-being. So it's a really exciting time for us. We have a number of distinguished speakers here today for you, but firstly, could I just cover a few housekeeping issues? We have no planned fire alarms today, so if the alarm is raised, we'd kindly ask you to leave the theatre with the direction of the ushers here at the top. And the fire exits are clearly marked for you. I also wanted to let you know that the launch is being recorded this afternoon and will be available to watch again at a later date. And we have a photographer taking photographs at the launch here as well. I'd also, just to remind you kindly to switch your mobile phone to silent, and that really covers all those issues that I need to cover. So firstly, I'd like to introduce our Vice-Chancellor, Professor Anthony Forster, to speak to us. Anthony.
David, thank you very much indeed. I'd like to offer my own warm welcome to everybody who's joined us today for the launch event, and I'd like to extend a very special warm welcome to Her Majesty's Lord Lieutenant of Essex, Mrs. Jennifer Tolhurst, Dr. Philip Tolhurst, Honorary Graduate of the University, to Sir Bob Russell, our High Steward at Colchester, Councillor Robert Davidson, Mayor of Colchester, Councillor Tim Young, Deputy Mayor of Colchester, and Deputy Mayoress Nicola Goodchild. And of course our guests attending today representing the National Health Service. It is truly wonderful to be meeting in person, and I might say making the best of both worlds. I'm delighted so many of our friends and colleagues have also been able to join us online, as David has said, both in the UK but also from around the world. And so a very warm welcome to everybody from Australia to Canada to Chile to Italy. We're delighted you could be with us. Thank you for your support. Thank you for joining us. It's a very exciting moment for us, indeed a very special day. Institutes at the University of Essex are very limited in number. We have 3, and our institutes are built on the excellence of our research, impact and innovation in strategic priority areas. And they enable us to bring together our world-leading researchers across multiple disciplines and our many partners and stakeholders in innovative ways to tackle real-world challenges and, above all, to improve lives. Our institute directors are globally recognised research leaders, and we always ensure that our institutes are outward-looking, that they are built on partnerships and sustainable partnerships with the public and private sector, with individuals and communities, and importantly with other universities and research institutes. Indeed, a hallmark of partnership working is the Essex way. And not only is it the way that we do things, but it's also the way we think about tackling challenges. Through our Institute of Public Health and Wellbeing, we're bringing together our core institutional values, our research excellence, and our key strategic partners to bear on tackling some of today's most intractable health challenges, including rising obesity, infant and adult mortality, a lack of sufficient access to mental health support, the stark health inequalities that appear only to have been exacerbated by the global pandemic. And at Essex, we believe good health and well-being for all is achievable by better addressing the multiple root causes of ill health and by taking a collaborative, interdisciplinary and global approach. This is our commitment, and this is why today we're launching our flagship research institute of public health and well-being. It builds on very significant work already underway at Essex. Professor Andrew Bateman in the School of Health and Social Care is working on improving social workers' knowledge around working with people with brain injuries. Dr. Anirban Chowdhury in our School of Computer Science and Electronic Engineering is working on brain-computer interface to help stroke patients' rehabilitation from disability. Professor Wayne Martin and our Essex Autonomy Project team have conducted a countrywide survey of care home professionals working during the pandemic, and a team of our historians have collected oral testimonies of women's health experiences in post-war Britain and are tonight launching a schools toolkit to help empower young people to take control of their well-being. Ariana Pulsani in our Department of Psychosocial and Psychoanalytical Studies is working with researchers in the School of Computer Science and Electronic Engineering to devise a virtual reality tool to help children with body image issues. And our data collection and storage experts from Understanding Society and the UK Data Archive continue to collect and provide data that is informing health and wellbeing research up and down the country. Our green exercise research team has transformed global understanding of the value of exercising in natural surroundings, and since coining the term green exercise back in 2003, it's our specialists in sports science and psychology and health and well-being, environmental sustainability and community engagement and behaviour change that have continued to demonstrate the benefits of physical activity whilst being directly exposed to nature. And finally, our ESRC-funded longitudinal survey, Understanding Society, is answering fundamental questions about nature versus nurture by analysing how our genetic makeup, socioeconomic characteristics and behaviours interact in very complex ways to shape our health and well-being. Through the leadership of Professor Chiara Di Cesare, our new director, Professor Rob Storsky, our new deputy director, Dr. Victoria Nolan, our executive officer and institute administrator, and a very exciting team of researchers and vital regional partners, we want to place scientific and medical and practice-based advances at the very heart of our commitment to good public health and well-being for individuals and communities. And so the launch of the Institute for us offers an exciting opportunity to make a specific difference to coastal communities and our regional communities, as well as global communities. And we hope to be able to announce some further plans, particularly in those areas, later in the year. Finally, I want to thank a number of colleagues who have allowed the launch of the Institute to take place today. Professor Chris Greer, David Omani, Vicky Joffe, Lucy Thomas have all turned the idea of an Institute for Public and Health Being from an idea on paper to a brilliant reality. I want to say a really warm and special thanks to our external partners, Phil Carver at Health Education East of England, Ed Garrett at North Essex CCG, to Mark Heisman at Provide, who's here with us this evening, and the many other colleagues who've offered exactly the right sort of challenge and, I might say, encouragement that we've needed to get the launch off to a fantastic start today. So thank you very much indeed for coming, and I hope you enjoy the presentations for the rest of the afternoon. Thank you.
Thank you, Vice-Chancellor. And now I'd also like to call upon Professor Victoria Joffe, our Dean of the School of Health and Social Care.
Oh, hello and welcome, everyone. How incredibly exciting it is to be here with you all today to launch our new Institute of Public Health and Wellbeing. My excitement, I must be honest, has been growing exponentially over the last few weeks and months. And yes, it may have something to do with the fact that I haven't really been out and about much over the last 2 years. But actually, I think my excitement runs far deeper than that, although I must say it is absolutely fantastic to see you all in person today. I have been really privileged to have been part of the team developing the vision and objectives for the Institute. And as Dean of the School of Health and Social Care, I can see so clearly how the inception of this institute provides us with an infrastructure that will support, magnify, enhance, and expand the work that we do in the school, in education, research and practice, in health and social care. I heard someone say the other day that the area of public health is really only something that the majority of the population think about when a crisis happens, like, for example, a devastating flood, or maybe even a pandemic. And this, I think, has certainly proved to be the case, with a massive new and heightened interest and greater awareness of health and well-being, nationally and internationally. We felt it most acutely in the School of Health and Social Care, with our recruitment numbers doubling over the last couple of years. It seemed that many people were looking for careers in the health and social care domains, looking to make a meaningful difference, as they had themselves observed so many others do over the pandemic. And I must also say, many of those were our own staff and students. But with this greater awareness came fear, misunderstanding, and the spreading of false information, making the need for education, research, and evidence-based healthcare even more important. As a school, it is our raison d'etre to develop and produce thoughtful, inquiring, and evidence-based practitioners who will become the future workforce and partner us in undertaking innovative, impactful, and applied research. The Institute provides us with many more opportunities to do this work with our students and our partners, and supports our own significant expansion. Public health is about supporting everyone: individuals, families, communities, organizations, and societies. Its focus is on improving, protecting, and promoting the health, both physical and mental, and well-being of us all. And indeed, this very idea of health promotion is at the essence of the Institute. And it is also what we are about in the School of Health and Social Care. And never has this been more important. Our recruitment strategy, for example, across all our programs, is specifically designed to open doors to those who might have thought that further education was not open and available to them. We have an incredibly diverse student body, which we are very, very proud of. And in fact, we are launching 3 new apprenticeship programs next year in nursing and therapy services in order to increase our diversity and ensure everyone who wants to has these opportunities. This inclusivity is embedded in our research too, where we promote work on access to services, exploring the needs of marginalized and vulnerable groups, working across the lifespan. We tell our students there is no such thing as the hard-to-reach community. There is only recruitment strategies and methodologies that are not fit for purpose and need further development. The Institute will provide greater opportunities for our students and partners to do this work through the development of a range of clinics and hubs serving our community and providing very valuable placement experience for our students. As I look around the room, I see so many of our partners, stakeholders, collaborators, service users, and indeed members of our own specific school service user reference group. You are all such an integral part of everything we do in the school, from advising us about what new courses we should develop in order to serve the community and fill the gaps, to co-producing these courses and our research. Indeed, you helped shape this very institute, and our co-production will continue as the Institute provides us all with further opportunities to collaborate. Health and well-being belongs to everyone, and this is a time when a strong health and social care workforce is imperative. This is exactly the business of the School of Health and Social Care and this university, and the Institute accelerates our key drivers in education, research, and practice, facilitating the development of graduates who challenge health inequalities, put people first, ask the right questions, and make evidenced, informed decisions to impact significantly on the lives of service users and our communities through research and practice. So you see, my excitement is much more than getting out of my Zoom room, and very much about being part of this venture, being part of something really special, really important and inclusive. And it is a journey we take together as partners, and it is one that I know my colleagues relish. So thank you all for your partnerships, your collaborations, and for being our critical friends. Please continue to ensure we reach the very high standards which we set ourselves, so we can be the change that we want, or probably that we need right now in the world. Thank you very much.
Thank you very much, Professor Joffe. And now I'd like to introduce to you our speaker, Professor Sir Michael Marmot, who will be talking about Build Back Fairer. I think Professor Marmot will be joining us virtually, so welcome.
Thank you. To talk about Build Back Fairer after the pandemic, I have to start with where we were before the pandemic. And in February 2020, my colleagues and I at the Institute of Health Equity produced Health Equity in England, the Marmot Review, 10 years on. We were looking back to the original Marmot Review, Fair Society, Healthy Lives, from 2010, and asked what happened in the previous 10 years. Next slide, please. And the third slide shows life expectancy in England had been increasing about 1 year every 4 years for women and for men. And in 2010, 11, that just about ground to a halt. If you were in government that came in 2010 and you looked at that, you might say, wow, we were really powerful. We took a century-long trend in improvement in life expectancy and we did it. We slowed it down. If you were a bit more humble, you'd say maybe it wasn't what we did, but in fact there is some evidence it's what the government did. Next slide, please. Not only did health stop improving, but the inequalities increased. This is women. If we look at life expectancy for the least deprived 10% by region, what you can see is the regional differences are quite small, and life expectancy was improving a bit. For the most deprived 10%, the regional differences are much bigger. Life expectancy improved in London, but went down in virtually every region outside London. So this is where we were before the pandemic crashed upon us. Life expectancy had more or less stopped improving, inequalities were getting bigger, and life expectancy for the poorest people was getting worse. Next slide, please. This shows the regional differences in a bit more detail. If you're rich, it doesn't much matter where you live. So for the least deprived 10%, London and the Northeast, life expectancy is more or less the same. Then the greater the deprivation, the greater the disadvantage of living in the Northeast. In other words, the social gradient is steeper in the Northeast than it is in London. The dotted line is life expectancy 2010-12, and the solid line 6 years later. You can see life expectancy was improving across the board in London. But in the Northeast, it went down for the poorest decile, went down a little bit for the next decile, no change for the bottom 5 or 6 deciles, and only started improving near the top. Next slide, please. We're working in Cheshire and Merseyside. If we look at the various communities in Cheshire and Merseyside, the greater the deprivation, the shorter the life expectancy, or the less the deprivation, the longer the life expectancy. So what we see nationally, we see playing out in that region. Next. And we're also working, next slide please. And we're also working in Lancashire and Cumbria. We see the same thing. In my 2010 review, we had 6 domains of recommendations. Give every child the best start in life, education and lifelong learning, fair employment and good work for all. Number 4 was having enough money to lead a healthy life. Number 5, healthy and sustainable places and communities. And the 6th was taking a social determinants approach to prevention. I'm not going to run through all of these, but what I can say is there were adverse trends in most of them. Next slide, please. The government that came in 2010, had as an explicit policy rolling back the state, reducing public expenditure, and they did it. In 2009-10, public sector expenditure was 42% of GDP. That went down year on year. By 2018-19, that 42% had become 35%. They really did it. Next slide, please. In my 2010 review, I coined the rather awkward phrase, proportionate universalism. I was trying to marry 2 ideas. One, classic British approach to social policy, which is target the worst off, and what we might call a more Nordic approach of universalist policies. So I tried to combine them, proportionate universalism. Next slide, please. So here's the social gradient. Let's say less deprivation, longer life expectancy. If we focus only on the worst off, we miss the health disadvantage of all these people who are relatively worse off than those at the top, but are not in the worst off group. You could almost call proportionate universalism leveling up. So what did we get post-2010? Next slide, please. This is spending by local government, by level of deprivation of the area. In the least deprived 20% of areas, Total local authority spending per person went down by 16%. And then the greater the deprivation, the greater the reduction in spending. In the most deprived, it went down by 32%. What we've got here is spending inversely proportionate to need. The greater the deprivation, the greater the need, the greater the need, the greater the reduction in spending. Could this have played a role in the slowdown and improvement in life expectancy, the increase in inequalities, the worse health in poorer areas? Yeah, I think it could. Next slide, please. I said I won't focus on all of my 6 domains, but let's look at children. Next slide, please. Child poverty. Before housing costs in 2010, 18% of children were in poverty. This is a relative measure defined as less than 60% median income. After housing costs, that went up to 27%. And over the decade, the 27% went up to 30%. The removal of the upgrade to universal credit arguably will throw 300,000 more children into poverty. It's a political decision, the level of child poverty. Next slide, please. And this is how those political decisions operate. Data from the Institute for Fiscal Studies. This is change in net household income due to tax and benefit reforms by income. So the red is working age families with children. If they were in the poorest household income decile, their income would have gone down by 20% as a result of changes to the tax and benefit system. The second poorest decile, 12% reduction, 9%. Then the richer you were, the less the reduction. Some reduction at the very top, but nowhere near as big as the reduction at the bottom. This is government policy to increase inequalities and make poor people poorer. Next slide, please. And cuts to local services, including counselling for young people, may also have had ill effects. Next slide. After a small dip, violence increased. And it shows a social gradient. Violence increased most in most deprived areas. Next slide, please. Public health is more than much more than just spending on public health. That said, there were dramatic reductions in public health right across the country. That's the England reduction. And there were dramatic reductions right across the country, varying by region. Next slide. And then came the pandemic. The pandemic exposed the underlying inequalities in society and amplified them. Next slide, please. There's the social gradient in all-cause mortality. The greater the deprivation, the higher the mortality. And the pale green is COVID-19. The higher the deprivation, the higher the mortality from COVID-19. It looks very similar to the gradient in mortality from all causes. Yes, we have to control the virus, and we did not do a good job of that. Still not. But we also have to address the underlying inequalities in society, and we're certainly not doing a good job at that. Next slide, please. I said we're working in Cheshire and Merseyside. There's the social gradient in mortality from COVID-19, a remarkable gradient. Next slide. And in Lancashire and South Cumbria, again, a remarkable social gradient in mortality from COVID-19. Next slide, please. And we had high excess mortality in the first wave of the pandemic. So excess mortality is total deaths compared with what would have been predicted based on the previous 5 years. And in the first wave, this is the UK, we had the highest excess mortality in the world. The US was a disaster and we were worse. The US is now higher than us, but we're still right up there in high excess mortality. Next slide. We can skip that. Next one, please. And I ask myself, what's the link between the fact that pre-pandemic life expectancy was stalling, inequalities in health were increasing, and life expectancy for the poorest people was falling, and that slowdown in life expectancy was nearly the slowest of all rich countries. Only Iceland and the United States had a slower improvement. And then in the pandemic, we had the highest excess mortality at the beginning and towards the highest later on. And what's the link between these two? And I think poor governance and political culture, increasing social and economic inequalities, the reduction in spending on public services, and the fact that we were not very healthy coming into the pandemic. Next slide, please. I get asked a great deal is what can the health care services do? We produced a report on what doctors can do, and I got nurses to produce a report on what nurses can do to tackle the social determinants of health. Next, please. And we've been working in regions around the country. We did a report for Greater Manchester, Build Back Fairer in Greater Manchester, which we published on the 30th of June last year. Next slide. This was front page of The Guardian, England 2, Germany 0, jaw-dropping fall in life expectancy. As an American friend said, he thought both headlines were jaw-dropping. Next, please. And indeed it was. For 2020, life expectancy for women fell 0.9 years in England, 1.3 years for men. And in the Northwest, 1.2 years for women, 1.6 years for men. That is jaw-dropping. Next slide, please. Our approach to building back fairer, a framework, these essentially are the 6 from our 2010 review, and then these spokes. Next slide, please. Build back fairer for future generations, build back fairer resources, build back fairer standards, institutions, monitoring and accountability, and devolution. Next, please. So, to build back fairer, I would argue we need action on these 6 domains that we identified way back in 2010 and reinforced in our subsequent reports. Give every child the best start in life, education and lifelong learning, fair employment and good work for all. Everyone should have at least the minimum income necessary for a healthy life, healthy and sustainable places and communities, and taking a social determinants approach to prevention. But, as the next slide shows, we also need to address poor governance and political culture. We need to stop and reverse the increasing social and economic inequalities. It's not enough to say austerity is over. We need to reverse the reduction in spending on public services, which were, as I showed you, most regressive. And we need to deal with the fact that we're not very healthy as a measure of societal success. So my overall recommendation is put a fair distribution of health and well-being at the heart of all government policy. Thank you.
Thank you very much, Professor Michael Marmot. Really stimulating talk there, setting out some of the challenges for public health and well-being as we go forward. I'd like to now introduce you to Peter Cook, who's the Assistant Director of Innovation at East Suffolk and North Essex NHS Foundation Trust.
Thank you. I suppose I'd like to start by thanking David and Lucy for putting me right after Sir Michael. The danger is that you're all now thinking about what you just heard. The worst danger is that I'm now thinking about what I've just heard and not really concentrating on what I'm doing. So hopefully this works. So I was asked to talk about partnership working and sort of touch upon health inequalities, and I had choices between saying something theoretical about partnership working, which will all sound quite twee and obvious to everybody anyway, so what was the point of doing that? Or talking about health inequalities in a way that I don't particularly understand, and following Sir Michael's excellent presentation would be a bit meaningless as well. So what I thought I'd do was just simply take you through a couple of real-life examples that myself, the team at ESNEFT particularly, and working with partners, a whole range of partners, have been doing that has a practical effect, I think, on some of the local issues that we've just heard about. So I just want to talk about a couple of examples. Example one, and I probably should ask for forgiveness if I miss out any partners that have been involved in any of these. It's not deliberate. I was just trying to get together a presentation that made sense to me and to you. So we've opened up a community diagnostic centre at Clacton Hospital. It's a £23 million capital project. The CDC, the Community Diagnostic Centre, is looking to deliver 180,000 diagnostic tests a year, which will be a phenomenal jump from where we are at the moment. And it's not an accident that we're actually situating this at Clacton, which I'll come on to. But interestingly, at the moment, or up till now, about 60% of the diagnostic tests that happen at Colchester Hospital are for people who are coming from tendering and travelling from tendering. So for all sorts of reasons, it makes logical sense to place it in Clacton. And I've listed there a number of the organisations involved in this, but I'm sure that's not an exhaustive list. And again, apologies if I've missed anybody off. And you can see there the kind of four main aims in terms of what we're trying to do from a delivery point of view. So back in 2021, which still seems a long time ago now, there was a national a recommendation to introduce a number of community diagnostic centres around the country, partly to try and move away from acute hospitals for infection control reasons, but also simply just to try and increase the capacity we've got in the country. And we were one of the first, I think, in this locality to launch the CDC where we have done. And I won't go through all the range of services because I'm sure you'll get these circulated afterwards, but you get a feel for the kind of things that will be going on there. I won't dwell on these for too much, but the Suffolk and North East Essex footprint that we are part of, that's obviously a heat map for deprivation, and you can see the darker the colour, as usual, is where kind of the worst deprivation is, and you can see the bottom right-hand corner where it works out darker, and a more localised view of tendering, and you can see it all gravitates around a certain part of the geography. One of the things that I haven't done this, but obviously someone's spent quite a lot of time looking at travel times, but in some cases it takes 2 hours from door to door from some parts of tendering to Colchester, which in itself is a barrier to access and not the kind of thing that people who are having to come to the hospital anyway to have a diagnostic test want to go through. So for all those reasons, X marks the spot. That's where the diagnostic centre has opened up. We've got mobile units there at the moment, but we're in the middle of refurbishing and building a new fit-for-purpose diagnostic centre. And there's just some of the highlights in terms of the inequalities that this is looking to address. The bottom one's quite interesting as well, which it hadn't really occurred to me in terms of car ownership, and it just exacerbates the issue about access and travel. And some of the points there are similar kind of points that Sir Michael raised. One of the, and lastly on this, one of the things that we then needed to do is to work out, well, who's going to go and work there? Because if all we're doing is taking existing diagnostic staff that we've got in the service and just spreading them even thinner, then that's not really going to lead to any additional capacity. So we've managed to get some government funding, and in partnership with Culture Institute have established a community diagnostic training centre at Clacton Hospital. It's in some temporary accommodation in the main building at the moment, but we've got a purpose built training room, training facilities going in there shortly, and we're working at the moment out of the Institute and the Iceni Centre in Culture Hospital. And we're engaging with local people, often from backgrounds of unemployment, getting back into work, from raising a family, changing sectors of work, given the fact that people might have lost their jobs in the slowdown in the economy, etc., etc. And through that programme, we're working with them to get them into particularly entry-level jobs in the diagnostic centre. When the centre's up and running, there'll be a huge number of entry-level jobs. But also what we then want to do is to see that as a springboard to train people up locally for some of the more senior jobs that we've got massive shortages for in terms of radiography and the like, and it gives really good employment opportunities for local people. And there's a series of interventions there you can see in terms of masterclasses, work placements in the front line at the trust at the moment, and guaranteed interviews to create opportunities for 50 people to get into real jobs at Clacton. And the point I'm making there is, growing our own at the bottom there in terms of people for the future. So that's example one. Example two, and when I was writing this, I found it quite difficult to remember everything because the last 2 years has been a bit of a whirlwind for everybody. But I was heavily involved with a very hard-working team at the Trust, working with a whole range of partners on setting up COVID testing locally. Initially for the Trust and for West Suffolk Hospital, but then more widely working with local authority partners and everybody else in the system to try and make sure that we had COVID testing facilities for key workers and key target groups who were in a vulnerable position. And I won't go through all this word for word, but back in March 2020, when it all started off, we literally had no in-house testing capability for COVID at the Trust or at West Suffolk. We were the only network amongst all the NHS trusts in the country that had no facilities. So we, like a lot of other people, were outsourcing all of our testing to Addenbrooke's, which was fine initially, but very soon that became clogged up. And in its worst, we were waiting for 8 days to get an indication of whether someone was positive or negative, which, from a logistical point of view, in terms of dealing with patients and admitting them into hospital, is clearly creates havoc and is very unfortunate for everybody concerned. So we went from there to establishing our first testing equipment in the Trust, and there's a whole load of obviously scientific testing and validation that needs to go through that. To the point that in probably about a year later, we had performed the 6th most COVID PCR tests in the country amongst the NHS Trust network, including Public Health England. So we'd gone through a phenomenal journey from zero, literally zero, to the 6th most, and I think we lie 7th, I think, now in the country. We went from zero to July 2021, the capability for about 3,000 PCR tests a day, and a new molecular laboratory that we got funded for and built in quick succession at Ipswich Hospital, which is all very snazzy, but it leaves us also with a local legacy for future testing capability. And I suppose the point I wanted to kind of stress with this is that not only did we go from zero to 3,000 and a molecular laboratory, we couldn't have done it without a partnership of all sorts of institutions and organisations that were involved, whether it was the private sector, both in terms of some of our outsourcing work and some of our logistics colleagues in the private sector who work for us, who went over the odds to try and do things that they wouldn't ordinarily do. at one stage we had equipment in I think probably at Frankfurt Airport, and we had the people from the garrison fly over to pick it up, to get it to us within 24 hours. So, you know, this wouldn't have happened without a huge amount of partnership working. And I would have thought this is probably as a good example of tackling a public health issue as you're going to find. And obviously, at the end of all of this, I know it affects everybody, but I think the evidence over the last 2 years has shown that people in a vulnerable situation have suffered even worse. So that was just a quick run through of just some practical examples of, I think, where the system has worked, partnership has worked. It's, you know, people have managed to get across any organisational boundaries and put aside any sensitivities around anything and just got on with the work and got delivery done for the well-being of everybody. So I think that's me. Thank you very much.
Thank you very much, Peter. And straight on to our next speaker, Mark Heisman, the Group Chief Executive for Provide.
Thank you very much indeed, David. And I must say, it is tremendous to be here. An event like this, the launch of a new institute, doesn't happen that regularly, does it? And to be involved at the start of something is always very exciting. So it's tremendous for us to have a chance to be here today with you and to have an opportunity to share a little bit about the importance of partnership working. So my name is Mark Heisman. I'm the Group Chief Executive at Provide. So we are a community interest company, social enterprise, based in Colchester. I've been on the board for 8 years as the Vice Chair and then the last 2 years as the Group Chief Executive. It was an interesting time to move into the health and well-being sector in the middle of a pandemic. Many of my friends thought I was absolutely crazy, but actually it's been a superb way of really understanding some of the challenges that we face in our sector, and also to have an opportunity to see how we can respond to it in different ways, and the imagination and creativity that's come through, and the depth of partnerships has been extraordinary. So a little bit about Provide to put it into context, because some of you will know an awful lot about us, some of you will have no idea at all. We span out of the NHS about 10 years ago, and we provide 3 main activities now. There's 3 main legs to our stool. When I do the staff induction, I call it our milking stool. 3 main legs to that. And that's our work with the NHS. And we provide a whole range of community services across Mid and South Essex and beyond. Then it's our work with local authorities, and we do a lot of stuff in the well-being space. I'll talk a little bit more about that later on. And then we have an enterprise, self-pay, and business part of our organisation. And the 3 of those add together to give us a very sustainable model in that whole health and well-being space. We're primarily Essex-based, though we do provide services around the country. We've just recently taken over the Child Health Information System, CHIS, in Dorset, and we run various other health and wellbeing services around primarily the home counties. Our vision is transforming lives, and I think that, for me, sums up Provide and sums up our relationship with our partners. We're looking for partners who are all about transforming lives. I'm going to give you 2 examples of those in a minute. We have various partnerships, and with every single one of those partnerships, there's 3 main things that excite us about why we want to get involved. First is synergy, where the whole is greater than the sum of the parts. The second is efficiency, keeping the main thing. And thirdly is benefit. What is the benefit to the communities that we serve? So we are a community interest company, and the community and company bit are 2 really important things, particularly community. And we're about putting stuff back into the community through the partnerships that we have. So the first example I'd like to just briefly talk about is our community collaborative in the system, the health system that we're a part of. So we're part of the Mid and South Essex system, which is this £2.5 billion system providing health and social care across Mid and South Essex. And in that, there are 3 main providers of community care and support and services. We're one of those as Provide. The other two, is ePut, the Essex Partnership University Trust, and the other one is NELFT, the North East London Foundation Trust. So the three of us provide services, and very effective in doing so, but often in quite an unjoined up way. When I was appointed a couple of years ago, one of the first things I did was to go and spend some time with our various partners around the system. And I went to go and see a lady called Claire Paniker, who is the Chief Executive at Broomfield Hospital. She also runs Southend Hospital and Basildon Hospital. And I said to her, what are you looking most from us as a community provider, as a partner with you in this health and wellbeing space? And she said, what I'm looking for is for you, 3 community providers, to do things in a similar and joined up way, to have a consistency about how you treat and deal with our service users, our patients, our customers, to have a common style of delivery, have a common name about what you call the services that you offer, and an improved level of service that you can work on together rather than individually. That really has driven a lot of the work we've done over the last 2 years. And we're working as a board, and we're now a collective, joint, collaborative board. In fact, I was at the board meeting this morning with the other chief executives from those organisations and the chairs from those organisations. And we meet on a regular basis, and we have a whole infrastructure put in place now. So it's not just a piece of paper, it is actually a whole series of activities, shared posts, looking at things in a place-based activity, working very closely with our other partners, like our local authorities and beyond, to reduce variation, to ensure sustainability, and to ensure that we have integrated health and care partnerships wrapped around primary care. So that absolutely drives what we're doing as we provide services into the community. That's one of the key things that we're doing in our community collaborative. And an example of how that practically worked its way out over recent months is with this next wave of COVID that we're just sort of coming out of, thankfully, we were able to put in place a virtual hospital. We were able to put in place 4 emergency community wards, 3 frailty wards, 2 respiratory wards, all established as a partnership with Provide, ePut and NELFT, working very closely together with other partners in the systems. So our aim is to dramatically improve health and well-being and address multiple sources of where those areas need to be addressed in that area through our partnership. So that's one example. The second example is really much closer to home, actually, and that's our partnership here with the University of Essex. That's been going for nearly 10 years now. And in fact, I was just looking through some of the paperwork about how we set it up 10 years ago. Provide was established to establish a mutually beneficial research, employability and knowledge exchange activities with the University of Essex. And that involved a whole variety of things, supporting the education and professional development of existing staff, offering opportunities to students and the University of Essex to develop an informed understanding of modern health and social care through internships, providing opportunities for research relating to health and social care, to foster innovation in each organisation and to facilitate knowledge exchange between each. Well, that has been extraordinarily successful. And over the last 10 years, we've been able to invest over £400,000 into the university. And that's one of the benefits of being a KIC, a community interest company, is that we will actually be able to put back into the communities. And our relationship with our academic institution here is so important to us because we can put that back into it. We've had research, we've had graduates, we've had placements, and most recently we've had a KTP, a knowledge transfer partnership, which has just recently come to an end. The KTP, some of you will be aware of KTP, some of you will be a complete anathema, but it's a project which sought to create a groundbreaking decision-making engine using AI and natural language processing to reduce the frequency of face-to-face clinician appointments in a defined healthcare test area, guided by psychosocial research into acceptance and adaptation of technological innovations in healthcare. If anybody would like to repeat that, then you get a prize. But that was an example of a piece of work which we did over several years, has just recently come to a conclusion, which resulted in a whole range of new activities that we are now adapting and using in Provide. We started a bed bureau. We had a Liberate platform to aim to reducing high amounts of return clinical visits. We had an asset management platform come out of that, and we had a staff resource platform. And in fact, practically what's come out of that is the formation of Provide Digital, which is a business now which is part of the Provide group, and we employed the people who ran the KTP here. They now, as part of they're one of our colleagues in our own workforce in the organisation, so they've come on board and are now setting up to grow and develop that organisation as we go forward. So that's just a practical example of what's happening through the partnership that we've had with the University of Essex. But it doesn't stop there, because we feel that as an organisation it's really important for us to continue that relationship with the university. And one of the things that I'm very proud of the opportunity to do today is to ask Anthony if you'd like to just come up here, please, because I have a cheque for you. And what was your surname, please? I just need to make sure I get that right. So we have a cheque here for £135,000, which is to fund the Provide Research Fellowship over the next 3 years. And that's one of a new series of fellowships that you're going to have here at the university, and we're delighted to fund the first one of those and to work closely with you as we as an organisation get involved in the day-to-day running and delivering of health and social care across our area. You are helping us to look forward and to identify what's coming up in the future with that thought leadership. So thank you very much indeed.
Thank you.
So this is a flagship. This Institute of Public Health and Wellbeing is an extraordinary place, and we're delighted to be a part of it. We're looking to deliver good for the wider community together with the university to truly understand and address the challenge in public health and wellbeing in Essex and beyond. And it's a privilege to be part of that together. Thank you very much indeed.
Thank you so much, Mark. I'd now like to introduce you to our new director of the Institute of Public Health and Wellbeing, Professor Di Cesare.
Wow. Thank you very much. Thank you, David. And I would like also to thank the speakers before me, Anthony, for believing in this project, Vicky, for giving a fantastic link with the School of Health and Social Care, and for the work done so far, and Mark, Sir Michael, for sharing with us the vision about how to close the gap in inequalities, and Peter and Mark for your contribution, and in particular for showing us how partnership that is based on same missions and same vision can bring us how much we can do and how far we can go. So we are here today, this is the, well, it's just this one. We are here today to celebrate the launch of the Institute of Public Health and Wellbeing, and this is an institute made by the community for the community. And what I think is that I would like to bring in the Institute the voice of all the amazing researchers, professionals, organizations, and communities that are already working on finding solutions to public health and well-being challenges. With the launch of the Institute, we are setting a milestone to enhance interdisciplinary work and impact for the future to strive for better health and well-being for all. In his keynote speech, Sir Michael has reminded us of something that we have taken for granted for decades. I'm a demographer, so life expectancy have been trained as something that was increasing over decades, but this is not the case. We have seen that life expectancy is stalling in some group of the population, declining in other, and the gap between the wealthy and the deprived area is increasing. And I think that we all agree this is not right. In January 2020, the World Health Organization released a list of urgent global health challenges that we have face in the coming years. This includes connection between climate and health, the health of people living in fragile and conflict-affected areas, which is today is particularly important, the persistence of health inequality, preparedness for epidemics, the impact of environmental risk factors on health, access to healthcare. And when the list was released, and I really need to read you this, the WHO director, Dr. Tedros, said countries invest heavily in protecting their people from terrorist attacks, but not against the attack of a virus, which could be far more deadly and far more damaging economically and socially. A pandemic could bring economies and nations to their knees. And this was January 2020, just 2 months before the first global lockdown. So we are now 2 years into the pandemic, and we cannot ignore that that call for tackling those global health challenges was real. It wasn't just a list of challenges, it was really there. And we have been forcibly reminded that public health doesn't stop at the national borders, and neither at those, or nor at those local invisible borders. Yet we are still not effectively tackling the need for health equity. So what I put here, oh, the title moved, it was central, but that's fine. This is a map showing you the proportion of population that receive at least 1 dose of COVID vaccine in the world. So the light color means low percentage, the dark color means high percentage. And for people that work in global health, this is unfortunately a very familiar map. Once again, during this pandemic, we are failing to provide access to diagnosis, treatment to all. And when I say all, I mean individuals, households, community, and countries, regardless to their ability to pay. As soon as the first COVID-19 vaccine was available and getting on the market, there were countries that were able to secure 5 doses of vaccine per person, and others that failed even 1 dose. So this is one example, just to bring a bit the global vision that I selected today. I could have gone with many other examples: access to healthy food, healthy environments, functional health systems, technology, access to technology and diagnosis. But essentially what reminds us that the journey to the right to health and well-being is still largely ahead of us. So our Essex community has the potential to help tackling these key global health challenges. Improving people's quality of life is what motivates the community and what we are passionate about, and we are inspired and innovative because we want to help real people, because we are those real people. So let's not make a distinction. We are those people. So Anthony presented some, mentioned his introduction, some example of the work that is done already within the University of Essex, and that amazing colleagues are leading. I have a few more examples for you. The work of Professor Papadopoulos from the Department of Psychosocial and Psychoanalytical Studies on refugees. And his therapeutical approach to improve refugees' plight by revolutionizing the way support services are provided has had a major impact in the world, in the way that the best practice for the United Nations and really changed the paradigm through the world. The work of Professor Judith Bueno de Mesquita from the School of Law is supporting the progress and providing useful example of how national legislative and policy framework can support the realization to the right to health. And again, she's really working to ensure that international treaties on the right to health are turned into action. And I think something that Anthony has mentioned, the Essex Autonomy Project, School of Philosophy and Art History. So this is just to show you the wide of the work that is done across the faculties that has investigated the notion of autonomy and how this applied to care and how this has influenced the policy and practice in the UK and around the world, informing global reform on mental health and mental capacity legislation. So the Institute really is built on this already amazing work done within the University of Essex, and I will come to partnership later. And I think the Institute is here to support the effort of the Essex community, our internal community, but also the wider community of individual and organization that already daily work on trying to improve the health and well-being of the population. Is a place, the Institute, so Institute of Public Health and Wellbeing, the acronym is IAPHW, it's not particularly easy, but it's there at the center. It's a place where researchers are really committed to push boundaries, work across disciplines, and provide reliable and sound research, policy recommendation, and also insights to improve lives. So the Institute is really a hub of research, education, knowledge exchange. They all come together and to ensure that what we do is relevant and is for the benefit of the society and the economy. So the Institute is really built on these 4 pillars. The one at the top, social, biological, and environmental determinants of health. And this is to disentangle the complexity and understand the interaction of these factors and what are the pathway mechanisms to health. The second one, interventions, outcomes, evaluation, and policy, to ensure that efforts to improve the health and well-being of the population are translated into real impact. That is what we want, right? We really want to have an impact on the population. Well-being and health promotion, the third one, to progress the process of enabling, and Vicky before mentioned health promotion, but really to enable people to increase control over their own health and to ensure that they are empowered. So we use the word empowerment a lot, and it's important that we work to empower population. And the fourth one, that is human rights, community, participation, and voice. Because if we do not address inequalities, discriminatory practice, and then just distribution of power, and if we do not work with an empowered community, then all the work that we are doing and what we are trying to progress is not going to work and is not going to be sustainable. So if you see the depth and the breadth of the 4 research pillars of the Institute of Public Health and Wellbeing embeds really complexity and interdisciplinarity in its foundation. So instead of sitting in silos, what we want to work is to work together to understand interconnection and potential advances in public health and well-being. There are 2 cross-cutting themes. One, well, today we have been working and discussing and presenting on health inequality, because we want to see how inequality really impact on the health and well-being of the population. And the other big theme, that is the use of cutting-edge methods, quantitative, qualitative, including artificial intelligence techniques, and the need to ensure that what we are doing, the impact on improving health and well-being of the population, is really guiding decision and change practice. We also think that it's important and to use and adopt a life course approach to be able then to take early, appropriate, and timely action. And as I said before, research, education, knowledge exchange, and I think that if you want to think, is within knowledge exchange, but really community involvement is key for the Institute. As I said before, the Institute of Public Health is not sitting in silo. We really want to break the silos of disciplines to ensure that our research, through collaboration and intersectoral partnerships, can truly dig into the complexity of the public health and well-being challenges that we are facing at the moment, and we are facing at the local, regional, national, and global level. Because if we do not recognize that complexity, the solution is not possible. And I think that, again, the pandemic has really reminded us also about that, right? I mean, none of the single elements were enough to approach and to solve, to give a response to the pandemic. To be able to do this, we really need partnership. We have to work with partner and organization and public community to work together and find solution. So I was extremely, happy and excited to hear Peter and Mark, and also the generous offer from Mark to support a new fellowship, because this type of partnership is what really we need to ensure that our work, our research is translated into action and intervention and policy, so that has an impact on the health and well-being of the population. Last week, just to give you another example of international partnership, the university has announced a partnership with the charity Lepra to help people affected with leprosy and other vulnerable groups in the population and in the world. The focus of the partnership is really to work on projects and academic research to address current and pressing issues, such as human rights and advocacy, medical and paramedical science, social science, human science. And today I'm also happy to announce a new partnership with the World Heart Federation that is also supporting a fellowship. And we will work with them to develop the World Heart Observatory, that is a knowledge hub that aggregates data on cardiovascular conditions, biological risk factor, policies, policy response, social determinants of health, and health systems, so all in a hub. And the idea of this dashboard hub is really to inform evidence-based decision-making for health and population level, identify gaps and research needs, and also develop capacity for countries to collate and collect data. So if you think about the research, education, and knowledge exchange, this is another example. So, and here I just try to close this and say that the Institute is an inclusive space, and we want to foster dialogue with across the community of researchers, stakeholders, and any other party that is interested in the project and in public health and well-being. And we want to bring together new advance to the most important challenges that we are facing at the moment, and really trying to improve the health and well-being for all. And going back to what Sir Michael was discussing, almost 2 decades ago, the Commission on the Social Determinants of Health made a call for government and civil society to come together to really tackle and work on the social determinants of health, and because that was a way to achieve health equity, and for me it's really the pathway to social justice. Today we know that if Sir Michael and also Peter in his maps and figures and plots has shown us, is that we haven't done enough. And I think that the Institute, as director of the Institute, I don't want to be here in 20 years again and say what is of that challenge that we haven't been able to embrace, what is that we haven't done. So we acknowledge that the public health challenges that we are facing are not easy to solve. Otherwise, we wouldn't be here. We would have a different institute. But I think they are within reach, especially if we work all together. Thank you very much.
Thank you so much, Chiara. I said I was excited earlier at the outset. I'm really excited with the vision of the Institute for Public Health and Wellbeing, and that really does set out a wonderful roadmap that's really ambitious and will really set in train, I think, a whole range of activities and research that's going to be leading the way for the university and for our community. So thank you so much, Chiara. Now, as we come to the close of our event today, we wanted to mark the launch of our Institute of Public Health and Wellbeing here at Essex. We hold a collection of art from Latin America, the Escala collection it's called. It was founded in 1993 from research and teaching of art from Latin America at the University of Essex. And it's been staffed through our School of Philosophy and Art History. Now, the school's pioneering work in this field developed from the university's founding focus on Latin American studies, leading in 1968 to the founding of the Center for Latin American and Caribbean Studies and the BA in Latin American Studies. So Escala have generously loaned the university our newest institute in the university, the Institute of Public Health and Wellbeing, a piece from their collection of more than 750 artworks to display in our new building. And I'm delighted today to ask Her Majesty's Lord Lieutenant, Mrs. Jennifer Tolhurst, to come on stage and to unveil this piece of work for us. Lord Lieutenant.
Formally mark the launch of the Institute of Public Health and Wellbeing today.
Thank you so much, Lord Lieutenant. And I think that unveiling it brings an end to our main event here. So thank you all so much for attending our launch today. And thank you to all of those who have joined us virtually and in person today from right across the UK and right across the globe. We'd be really delighted if you were able to join us for our reception, where we'll be serving some refreshments. This will take place in the building next to the Lakeside Theatre here. So just coming out of the theatre on the left-hand side, the Silverbrad Student Centre. So we'll be starting that right afterwards. So thank you all for a wonderful evening, and look forward to meeting with you in person and informally in the Silverbrad. So thank you.